Hello everyone. So now we are discussing acute massive pulmonary embolism. So it is the third most common cause of cardiovascular illness, but still it is one of the most underdiagnosed conditions. Consider DVT and pulmonary embolism as one disease, and if pulmonary embolism is suspected, look for signs and symptoms of DVT. Absence of DVT does not rule out pulmonary embolism. According to Indian statistics, it is responsible for up to 15% of all the in-hospital deaths. So if a patient of massive pulmonary embolism is going to come to you, he is mostly going to come to you with hemodynamic collapse, cardiac shock, or an arrest, or extreme unexplained dyspnea or chest pain, and uncommonly with cough, hemoptysis, and syncope. The other signs which might be seen is tachypnea, tachycardia, signs of DVT, fever, and cyanosis. So this is the three ways by which patients of pulmonary embolism presents. Usually 5 to 10% are massive, which is presenting as hypotension, cardiogenic shock, or arrest, and in which the systolic blood pressures are less than 90 or more than 40 millimeters of drop in pressures over 15 minutes, or any patient who is maintaining pressures with high dose inotropes or vasopressors. The second most common is 20 to 25% intermediate presentation, in which the patients are normotensive with signs of RV compromise, also called submassive. And the third common presentation is more than 70% patients are stable, in which they are normal blood pressure, normotensive with no or mild risk, which is also known as low risk patients. So everybody knows this Wells clinical prediction rule. I'm not going to go through, but only the simplified version which is available, in which the score is more than 2, which is out of these 7 scores. If it is score is more than 2, then pulmonary embolism is likely. Also, the common Geneva clinical prediction rule, if the score is more than 3 now in the simplified version, then pulmonary embolism is likely. What more commonly I would like to discuss is the new PESI score, which is pulmonary embolism severity index, which should be measured in all pulmonary embolism patients, in which you get 1 point if the age is more than 80, a 1 point for cancer, 1 point for either CHF or pulmonary disease, 1 point for tachycardia, 1 point for hypertension, and 1 point for saturation is less than 90. If you have any 1 point, then your 30-day mortality is going to be 11%. So initial risk stratification for acute pulmonary embolism, if any patient has shock or hypertension, then he is classified as high risk, like our patient of massive pulmonary embolism, as we initially defined, a pressure is less than 90 or a more than 40 millimeter drop over 15 minutes, which is not caused by any new arrhythmia, hypovolemia, or sepsis. So any patient of pulmonary embolism, if he is not hemodynamically stable, he is high risk pulmonary embolism or a massive PE. If he is stable, then you have to do three things. One, you have to calculate his PESI score. You have to check his RV function either by a echo or by the CT, and you have to calculate his troponin levels. If all three are abnormal, he is intermediate high risk. If two are abnormal, he is intermediate low risk, and if all three are normal, he is low risk PE. So this is how we do the early mortality risk stratification, in which it is a high risk if he has hemodynamic instability, his PESI score is high, he has RV dysfunction, and troponin levels are high. So all the four ticks out, then he has high mortality risk. If he does not have hemodynamic instability but the other three are positive, then he is intermediate high risk. If he does not have hemodynamic instability, and if he has either RV dysfunction or troponin positive with a high PESI score, then he is intermediate low risk. And if everything is negative, then he is a low risk. So pathophysiological pulmonary embolism is that there is an anatomical obstruction because of the clot. There is hypoxemic vasoconstriction and neurohormonal effects leading to increased PA pressure, RV afterload, and increase in the PVR, leading to RV dilatation, dysfunction, decrease in RV output, interventricular septal shift of the LV, leading to decrease in LV preload, decrease in LV output, causing decrease in systemic perfusion, hypotension, also decreasing coronary perfusion, causing decrease in RV oxygen supply, causing decrease in RV ischemia, and so on. And all these things can be studied just by a bedside echo. Also, do not forget the 60-60 rule on echo, which is disturbed RV ejection pattern, which is RV acceleration time of less than 60 milliseconds in presence of TR gradient less than 60. So all these pathophysiologies can be studied on echo, which is increased PVR and RV pressure overload by our TR gradients, your RV dilatation, hypokinesis, and interventricular septal deviation, which is D-shaped LV, abnormal LV filling by the E and E prime and A, your decreased LV cardiac output and systemic arterial hypotension by your compressed LV, and your RV ischemia, infarction, and failure, which can also be seen by the McConnell sign, which is apical sparing. So any high risk or massive pulmonary embolism patient, a bedside TE should be done, transthoracic echo, to check for RV dysfunction. If it is not there, you should then look for some other causes of the shock or instability. If it is there, then you should, if your CTPA is immediately available, then you can go ahead with the CTPA. But if it is not, then you should not waste time and you should directly begin a treatment for high risk P, which is usually lysis or anticoagulation. But if you have a CTPA and if it is positive, then you treat your patient with the lysis or anticoagulation. And if it is negative, then you search for other causes. So acute P, patient with shock, hypotension, P, arrest, it is high risk P, and if there are no contraindication, please lyse your patient. If there are contraindication, then you have to consider surgical embolectomy or catheter-directed thrombolysis. If it is low or intermediate risk P, as I mentioned, you have to check these three things, and if all the three things are present, it is intermediate high risk P, then you should consider lysis, or CDT is a low bleeding, if the patient is a low bleeding risk. And if that either two or one are positive, then it is a low risk or intermediate low risk, and patient is a candidate for anticoagulation. So how you do diagnose pulmonary embolism? By these tests. First is D-dimer. It has a good negative predictive value. It is less specific, but it is used to ruling out pulmonary embolism in low clinical probability patient. So ECG, what an ECG will show in massive pulmonary embolism? Sinus tachycardia, right axis deviation, right bundle, a new RBBB, RV overload in V1 to V4, like ST depression, T inversion, V1 to V4, atrial fibrillation, your S1 Q333, right? You can also if you do a duplex ultrasonography, you may find evidence of DVT in the proximal veins. What will an X-ray show? So a normal X-ray in presence of severe breathlessness is diagnostic of massive pulmonary embolism. You can also have your Westermarck sign, which is focal oligemia in massive pulmonary embolism. But the other sign, which is Hampton's hump, is seen in peripheral pulmonary embolism, like your because of pulmonary infarction. And your Pallas sign, which is enlarged right descending pulmonary artery, is also seen in submassive to peripheral pulmonary embolism. So echo and trop and BNP we already discussed. Your CTPA will show you direct visualization of the filling defects. So what to expect in the ABG? The two most common gas exchange abnormalities are hypoxemia and increased alveolar arterial oxygen gradient. Some patient may hyperventilate, leading to hypocapnia and respiratory alkalosis. Hypercapnia, if it is present in a patient of high risk of massive pulmonary embolism, it is very bad because it is showing impaired minute ventilation and increased anatomical and physiological dead space. And hypercapnia is usually a poor prognostic indicator. So non-imaging diagnostic tests for pulmonary embolism are D-dimer, cardiac markers, and ECG, which we discussed. So what is the treatment? It is your goals are to prevent death, to reduce the chances of recurrent embolism, and to minimize the long-term morbidity due to the event. So hemodynamic support, although the initial strategy to manage hemodynamic instability is often to augment the RV preload by bolus IV, but excessive volume resuscitation may exacerbate RV failure by overdistending the RV, increasing the wall stress and worsening RV ischemia, decreasing contractility and causing further ventricular shifts towards the LV and causing decreased LV filling and decreasing cardiac output. And therefore, initial trial of IV volume is most likely to be successful in patients without signs of increased right-sided preload, such as those with CVP less than 15. While in patients of more than CVP more than 15, volume overloading should be avoided and administration of vasopressors and inotropes should be the initial steps in hemodynamic support. And vasopressors such as norepinephrine, epinephrine, dopamine have dual mechanisms of action as both inotropes and vasodepressors, and therefore may be preferred in initial support. While in patients with tachycardia, primary vasopressors such as vasopressin or phenylephrine may be most appropriate to avoid accelerating the heart rate further. So what is the treatment? Is heparin at unfractionated low molecular weight lysis, either systemic or catheter-directed surgical embolectomy, and IVC filter. So mainly anticoagulation and thrombolytics are the mainstay of treatment in massive pulmonary embolism. And when should you begin your anticoagulation? As soon as possible. So you all know 80 and 18, which we follow, 80 bolus and 18 units per infusion of the unfractionated heparin, and it should be continuous for at least 5 days before. If you are going to use a vitamin K antagonist, then your target INR should be more than 2, or NOAC, then as soon as possible you can just start your NOAC after your infusion. And or thrombolysis. So why thrombolysis is beneficial? Because it causes faster clot lysis, dissolves obstruction, may reverse the RV failure, dissolves much of the source of your pulmonary embolism, decreases the risk of recurrence. It is usually well tolerated, has excellent prognosis, but has some risk of hemorrhage, like up to 1.2% risk of intracoronary hemorrhage, mainly more in patients of non-massive pulmonary embolism. So if you see the trials which was done, the efficacy of systemic thrombolysis was very excellent in massive pulmonary embolism. So all the patients of massive pulmonary embolism who don't have any contraindications for lysis should be given this lysis. But whereas patients with intermediate risk and low intermediate risk patient should be evaluated further, their bleeding scores and should be calculated, and if low bleeding, they should also be lysed. But other trials such as the patho trial had shown high intracranial bleeding risk in patients of intermediate risk with tenecteplase. You should keep that in mind. Whereas safety, when it is concerned, the alteplase was found to be more safer than tenecteplase in terms of major bleeding and fatal intracranial hemorrhages. So these are the agents which are approved. Streptokinase, usually we follow 2.5 international units as a loading dose over half an hour, followed by 1 lakh international units per hour for 12 to 24 hours. There is an accelerated regimen as 1.5 million units over 2 hours, but it causes hypertension. Urokinase, we give 4,400 as loading over 10 minutes, followed by 4,400 per kg per hour for 24 hours. There is also accelerated regimen, but is not commonly used. Most commonly used is the alteplase. 100 milligrams has to be given over 2 hours, or maximum dose of 50 milligrams has to be given over 15 minutes, which is the accelerated regimen. Apart from this, there are two other agents like tenecteplase, which is weight adjusted, as we all use, and also reteplase, which is 10 and 10, which can also be used. So alteplase is the one which is more commonly being advocated, and total of 100 milligrams has to be given in 2 hours, and 10 milligrams is usually given as an intravenous bolus over 1 to 2 minutes, followed by 90 milligrams as an IV infusion over 2 hours. Or in patients with a body weight less than 65 kgs, 10 milligrams can be given as IV bolus over 1 to 2 minutes, followed by an IV infusion to a maximum dose of 1.5 milligrams per kg. So, what is the evidence of alteplase in acute pulmonary embolism? This was a trial PAIMS-2 plasminogen activator Italian multi-center study in which the alteplase was studied, and after this approval was given. If you consider alteplase versus urokinase in a study, then the pulmonary vascular resistance was decreased faster in patients who were given alteplase rather than those who gave urokinase. So you can prefer alteplase rather than other agents. So what do the guidelines say? There is class 1 indication for anticoagulation in all patients with high risk PE. There is class 1 indication for systemic thrombolysis. There is class 1 indication for surgical embolectomy in patients with high risk P in whom thrombolysis is contraindicated or failed. And there is class 2A indication for percutaneous catheter directed treatment in whom thrombolysis is contraindicated or failed, and use of inotropes norepinephrine and dobutamine. And there is class 2 indication for ECMO in combination for surgical embolectomy or catheter directed treatments for refractory patients with cardiac arrests. So any patients with pulmonary embolism, you should anticoagulate them. And if there is any hemodynamic instability, you treat them as high risk. You should reperfuse them, as we discussed. And if they are not hemodynamically unstable, then as we know, you should calculate these three things: the PESI score, RV dysfunction, and your troponin levels. And if all three are positive, then you should consider them for reperfusion or at least anticoagulate them. And if not, then you should at least hospitalize them and anticoagulate them for 5 days. So catheter-directed thrombolysis involves removal or disruption of obstructive thrombi from the main pulmonary artery and or local administration of small dose of thrombolytics directly into the pulmonary artery. The various interventional options include thrombus fragmentation with pigtail or balloon catheter, rheolytic thrombectomy, suction thrombectomy, aspiration catheters, and rotational thrombectomy. Concurrent administration of local thrombolytics can be performed via multiple side-hole catheters in the pulmonary artery with or without the application of ultrasound energy. And the only actually CDT is now only effective for MPA or its major branches and with less organized thrombus. The efficacy is limited by the relatively small size of the aspiration catheters compared with the size of the main pulmonary artery. It has the advantage of being better tolerated in patients with tenuous hemodynamics compared with surgical embolectomy and requires lower dose of thrombolytics compared to the systemic one. It has the advantage of increased efficacy of thrombus dissolution due to synergistic effects of higher local thrombolytic drug concentration as mechanical disruption with greater exposed thrombus surface area. Because higher local drug concentration is achieved with overall lower dose of fibrinolytic agent, it may offer the advantage of decreased hemorrhagic complication. But there is limited good quality data on hard outcomes on using CDT in pulmonary embolism. So it should be considered in high-risk patient as an alternative to surgical embolectomy when systemic lysis is contraindicated or has failed, or in intermediate high-risk patient if the anticipated risk for bleeding with systemic lysis is high. Surgical embolectomy is open surgical procedure in which the clots are to be removed from the right atrium ventricle or the main pulmonary arteries. It is indicated in patients with massive PE and possibly submassive PE who have contraindication to lysis, or when lysis or catheter-directed treatments have failed. So these are the treatment options which we discussed: in systemic lysis, catheter-directed lysis with mechanical disruption, surgical embolectomy, and ECMO. all have their pros and cons, each has their advantages and disadvantages, and it has each case, depending upon the bleeding risk, depending upon their pressure, depending upon their presentation, has to be individualized, and it cannot be just generalized that this every patient should be like. It has to be individualized, case to case. So what is the optimal duration for anticoagulation? If it is a first provoked proximal leg DVT, usually up to 6 months. If it is first provoked calf DVT or upper extremity DVT, then it is 3 months. Second provoked DVT, then a VT, then it is uncertain. Third embolism is indefinite always. If it is cancer, then usually it is indefinite or until the cancer is treated. Unprovoked proximal leg DVT is usually indefinite. First unprovoked calf DVT is usually 3 months, while second unprovoked calf DVT, the duration is uncertain. Thank you.